I know we are recording this session, so hopefully folks who are still stuck out in the security line can pull it up later and take a look. I am really excited and quite honored today to be welcoming our speaker, James G. Robinson, author of More Than We Expected, 5 Years with a Remarkable Child. My name is Michelle Oshman. I'm the Chief Patient Advocate here at BIO. I'm honored to be part of a wonderful team that is extremely patient-centric, as you all know. BIO's patient advocacy team has brought over 200 patient advocates to the convention this year, and a number of them, about 80 folks, are participating in partnering as well, non-dilutive funding and venture philanthropy that's really going to move the needle in terms of biotechnology and bringing more cures to patients. Last year, those of you who joined my Fireside chat were able to hear from David Feigenbaum, Dr. Feigenbaum of EveryCure, who's really leading a multi-million-dollar drug repurposing effort through ARPA-H dollars as well as Chan Zuckerberg dollars. To repurpose drugs, he was able to identify a long generic drug that essentially put him into remission of multicentric Castleman's disease after nearly dying multiple times, and that's where he's taking his passion forward. James Robinson brings a unique experience, bringing his passion forward as a journalist, as a writer, and as an adjunct professor at Columbia University School of Journalism. We're going to hear his family's incredible story, a story of humanity, a story of true perseverance, and really thinking about what it is that certainly we all do as we move forward to change people's lives. David will have a book signing after, just down the hall, and I do hope that you'll come and join that. So with that, I will bring, James will have a book signing after that, and I'll bring James up here, and we're just gonna have a chat. So come on up. Good morning.
Good morning. First of all, y'all can move closer. If this is going to be a fireside chat, we can actually have like a fireside chat. So,
thank you so much. And again, we know security lines, they can be quite fun. So let's go ahead and get started. Why don't you introduce yourself to our group and kind of give us a quick overview of your story, which of course we're going to go into in much greater depth.
Yeah, great. So great to see everybody here. Thank you for the warm welcome at BIO. I feel a little lost because I've never been to a convention like this, but I'm glad there are people who want to hear patient stories and caretaker stories and advocate stories. My name is James. I am the father of 3 sons who you can see there. This was taken a while ago. The guy on the right is actually just graduating from high school next week. He's 17, and he has 2 younger brothers who were born 4 years after him. Yaniv on the left just graduated from middle school yesterday, which is why I'm late getting up here. And the guy in the middle is the reason that I wrote this book. His name is Nadav, and he was born with a very serious congenital heart defect, single ventricle heterotaxy, caused by a genetic defect, which we actually didn't realize till much later. Which required 3 surgeries before the age of 5. After those 3 surgeries, which thankfully were successful, we decided to take a trip to Australia, which is where my family is from, and show the 3 boys a country that I loved. And unfortunately, Nadav developed a clot in his circulation while we were there, which required emergency surgery and led to a long hospitalization in Australia. And not to give away the ending, but we made it home because of an amazing medical team and miracle flight halfway across the world, recuperating in the Children's Hospital of Philadelphia, which is also not our home. We live in New York, and then finally made it back. The story has kind of a sad ending, which is that Nadav died shortly after that at the age of 5, 8 years ago. And although it's a sad ending, our story, I'm convinced, and maybe you agree, is not a sad story. And that's the reason I wrote a book about it. Which is to explain why parenting such a remarkable child, in fact, all 3 of these kids, but especially him, was such a privilege and really opened my eyes to some things I had never considered or never would have considered were we not put in this situation.
Thank you so much, and thank you so much for being willing to share your story. For folks who are familiar with what we do at BIO, we actually have a series about every 3 months. We bring in a remarkable family to share their story with the BIO team. it's so easy, I think, for folks who are either working in the lab and on the bench, or folks here who are really at BIO, who are really operationalizing and representing our companies, to feel a little bit distal from the experience. And so we're so grateful for families and parents who are willing to share their stories, because again, to each of us in this room and the hundreds who are outside in security lines, understanding the humanity behind, patients aren't just an N in a drug package label, right? Every patient, every family has a very special experience, and I so appreciate you being vulnerable and sharing that with us. You alluded to it a little bit, but more than we expected. So talk a little bit about the title.
Well, it's a bit of a play on words. If you write a book, the title is the hardest part, and we had big fights about the title on it. We settled on more than we expected, which I didn't like at first, but I actually quite like it now because it's sort of a double entendre. When you're expecting a child, and you expect certain things, and obviously when you have a child born with medical challenges, it is much more than you expected, right? Like the obligations are much more than you expected. When you have a child in this situation, when you first have a diagnosis, the first thing you feel is like sheer terror. Like absolutely, to know that your son will have to have 3 surgeries. The first one at the age of 5 days, right? The second one at 5 months, and the third one at 3 years. That is a very terrifying thing. It's a very human emotion. But the other thing that you feel, or at least what I felt, was a real source of wonder. Like, it was a real source of wonder for me. When you think about how the body forms, for example, when you have a healthy child born, as our first one was, you walk out of the hospital feeling just the miracle of life, how incredible it is that you've brought this new life into the world, that you've conjured this living being, right? But when you have a child born with a defect, it really opens your eyes to the miracle of how anything ever goes right, because it forces you to reconsider the processes by which the body forms. So in Nadav's case, what happened was his body formed the same way, similar to how our bodies all form. And I learned about this actually from a New York Times article after he was born. I didn't hear about this from any of the doctors. When you are conceived, you are like an embryo, right? And an embryo is perfectly symmetrical. And on the outside of this embryo are these little hairs called cilia, which beat the amniotic fluid in a certain way around the embryo, right? This is a couple of weeks old. And as the amniotic fluid swirls, it lays out the proteins in a certain way that determine how the body will form. So everything's working right, your body forms a certain way. If they're beating the opposite way, you get something called situs inversus, which means that your organs are reversed, right? They're back to front, mirror image. That happens, I think, once in every 10,000 births. And a lot of people don't even know it because there's no reason to know your organs are reversed. But if they're not beating quite right, the proteins don't form quite right, then your body is malformed, and that's what happened with our son. The cilia did not beat quite right, and his organs were wrong. It wasn't just his heart. His stomach was kind of in the wrong place, or a couple of things. He had no spleen. And when you think about that, especially as a parent, like that is absolutely incredible that that's how your body forms. That these tiny beating of these in the span of 3 hours, this happens, right? It's absolutely incredible. So there's a source of wonder that comes from that. I did not expect to have my eyes open to that, and now I'm grateful that I did. Maybe you all in the biotechnology medical field know about this, and hopefully you're filled with this sort of wonder. Like that's my hope, is that aside from the business stuff, you feel that wonder. So that's the second thing. And then the third thing is this sense of mystery. Like you think about like, how did this happen? And there are things that you will never understand. And I think part of medical innovation and medicine is trying to push up against the things that you don't understand and understand it. And certainly when you're in the situation, as we found in the course of our journey, there are some things that you will never know. And that is a real human thing as well, right? If we knew everything, we would not be human. And where that comes into focus most is in decision-making, right? Because you try to make decisions about the course of care, and there will be some cases where you don't know if you made the right decision. You'll never know. And that is a very human thing, and it sort of forced me to come to terms with the fact that that is a human limitation that we have. The other thing about humanity is you come to appreciate the fact that this all medical care is a human endeavor. You realize that doctors are not gods or saints or anything like that. They're human beings just like anybody else. And you realize that you have to deal with them as humans, and hopefully they learn they have to deal with parents as humans as well. I think to the first surgery our son had, it's called a BTT shunt. It was actually the first surgery ever performed, heart surgery ever performed on a kid back in 1946 at Johns Hopkins University. And the 3 people involved in the surgery were all very human people. The guy who decided to take the risk to do it, The guy who assisted him, who was actually his lab tech, who was a black guy, who was a carpenter's apprentice, who he hired to look after his lab, and then ended up walking him through the surgery because he was the expert in the tools and the techniques, right? This is an amazing story if you haven't heard it. It's called Something the Lord Made as a movie, which you should watch. And then the pediatric cardiologist named Helen Tausig, who was deaf, right, and had to navigate that. Like, you realize that everybody has these limitations, and that by working together, both on the medical side and the parental side, by acknowledging that humanity, you actually care, and that's what caring is. So it's a long answer to your question, but there were things that I had never expected to have to deal with or have to learn, and as I said, I'm very grateful for having gone through it.
So I shared with James, I've read the book 3 times. It's such a readable book, but also you're quite a good writer. I mean, I guess that's why you have a book, maybe. But, and I don't, because I'm not very eloquent. But you talked in the book about the BTT shunt, and it's often called the BT shunt, and talk about the third T, because I think the individual's name and sort of, you mentioned him, but...
Yeah, this is the story I just told. So Vivian Thomas was hired by Alfred Blaylock, who was a surgeon at Vanderbilt and then went to Johns Hopkins. He was hired as his lab assistant to run the lab, he was studying shock, and he was inducing shock into dogs. That was his job. And to do that, he had to develop a sort of set of medical techniques to do that and medical tools to do that. And when Blaylock and Tausig got together and said, we can save blue babies or help blue babies by doing this surgery, which was unheard of, by the way. Like, the remedy for this was they put the kid on their back and they put their legs in the air, right? That was like how you dealt with a kid who did not have enough oxygen in their bloodstream. Blaylock and Tausig got together, and that's why they called it a BT shunt, because they were the ones who came up with the idea. But Blaylock, when he was considering how to do the surgery, realized he needed Thomas in the room, which was a huge scandal, because he was not a doctor, he was black. They didn't let him in the front door at Johns Hopkins. He had to go in the servant's entrance, right? And in fact, the chief anesthesiologist there would not participate in the surgery because Thomas was there. Blaylock insisted that he be there, and he actually leant over his shoulder throughout the whole surgery and walked him through it as he performed the surgery, which is really, really incredible. I had the honor of actually speaking at Johns Hopkins a few months ago, and to be in that hospital where they devised the technique that helped our son. It was the first surgery that saved his life because his heart was not connected to his lungs. It was absolutely mind-blowing. And I feel the same humility when I meet anybody involved in research or innovation, because there's a huge amount of personal risk when you decide to do something that nobody has ever done before. And then the question is, what goes wrong? And a lot went wrong with our son, right? So I see that firsthand, the consequences of having regret about medical decision-making from the parent perspective, but also from the doctor perspective. Like, the doctors we worked with were very, very human people. And when our son, the big decision was whether we should have gone to Australia. This is a kid who's had 3 heart surgeries. You're going to put him on a plane halfway around the world. And the doctors who advised us to do it, or actually gave us permission to do it, or said that it was okay to do it, realized that caring for him was not just putting him in a bubble. It was giving him a chance to be a kid and giving ourselves a chance to be a family, which was as important as any medical consideration. And it was worth that risk. Well, as a parent in a situation, as a doctor, you are constantly evaluating risk and constantly evaluating your decisions in advance, and then, unfortunately, you do tend to do it in reverse. So the risk that you take when you decide to do a procedure that's never been done before or take a risk is not just to yourself and your professional reputation, it's also, it's not just to the family whose lives you're going to affect if it goes wrong, it's also to yourself and your judgment. And that's what we always worried about with doctors involved in this care, was that they would not be as innovative or as risk-taking or as, pushing the knowledge of what we don't know because of what they had gone through with our son.
And early on in the book, you really talk about the physician saying, look, he's our patient, but he's your son, right?
Yes.
And this idea that to your point, that he should be a kid. And your other kids are kids too, right? So you talked in the book about a drawing that the physician made just to kind of explain what was going on with Nadav's heart.
Yes.
And you had asked his older brother, hey, you have a new baby brother, how about if you draw a picture? Can you kind of articulate that? Because I think that's such a special, synchronous, I don't know, sort of wonder kind of thing.
So when you are forced to face these cosmic things, like how does the body form like this, and the unknown reasons behind it, which we will never know, right? I don't think we will ever know. We can have educated guesses. We can have faith, which is another topic, right? Like you search for these weird coincidences. You look for things that try to give like all this stuff meaning. And so the book is sprinkled with all these coincidences that I found happening while we were going through this situation. And one of them was right after he was born. The cardiologist, as most cardiologists do when they're trying to explain the anatomy to a parent, will draw a sketch of the anatomy of the heart. And it's got 3 loops because you're drawing both ventricles. That's how it starts out, right? And our son, Gilad, he was 4 years old. We'd never shown him this picture at all. We'd always tried to be totally honest with him. That's very important as a parent, is that you're totally honest. I still believe that about life and death and all the things. We never kept anything from him. Maybe we explained it in a way which was a little more comprehensible, but we wanted to make sure that he felt that he knew what we knew, because otherwise he would imagine everything to be terrible. But we never showed him this actual picture. Well, when Nadav and his twin brother was born, they were twins, right? I mentioned that they were twins, right? They're twins. I said, do you want to draw a picture for them? Because Nadav was in the NICU and he was, had all these tubes and everything. And I said, you want to draw a picture? I thought it might be a nice way for him to feel connected. So we gave him some crayons and a picture. And he sits down, he takes a pink crayon, and he draws, I kid you not, and there's a picture of it in the book, another reason to read the book, right? And the copies are free, so you can get one later. The exact same shape.
And it looked nothing like a heart.
No, it's just these 3 loops, right? And then he's like scribbled all these pink things on top, which I like to think were like the veins and the arteries and all that, right? But you look at that and you're like, wow, the hairs go up in the back of your neck. And you feel this connection to something indescribable, like something beyond your comprehension, which is inspiring and reassuring and all of those things at the same time. And then you start to grasp at those things, because faith is a large part of any journey, not just religious faith, but you start to think to yourself, how do you have faith that you're going to get through this? And these little coincidences sort of give you a hint that there may be forces beyond your control, the wind at your back, if you will. Yeah.
So going through this experience, again, I so marvel at the strength that you and Tali just going through this and the resilience, and then sort of this wild idea to go to Australia, as you mentioned.
Yeah.
So talk a little bit about sort of your thinking behind that, and then sort of the journey there. And it sounds like it was just a wonderful time to connect with your family and have your own grandfather meet your son. So
Yeah. My mother's from Australia. My father's from New Zealand, which is another country near Australia. But I have very fond memories. We used to go back every year because my grandparents were there and a lot of my family was there. And when Gilad was born, our first son, we brought him at 6 months down to Australia because I wanted to meet his great-grandfather. And it wasn't until I was there that you realize like how mind-blowing the concept of great-grandkids is. Like you just saw the photo of those kids. Like imagine if I met one of their grandkids. Like insane. So it was a very special thing. And we have a lovely photo of me and my mother and my grandfather with him and 4 generations and all that. And when the twins were born, we thought to ourselves, well, we want to show them the world, right? Like, this is our obligation as parents, is to introduce your kids to the world and show them the things that bring you joy. And we took that very seriously. We traveled a lot, even though Nadav's condition, sort of limited some of the ways in which we could do things. Just by logistics, we just tried to push the envelope as much as possible. We drove down to the beach. We went to San Diego. We just tried to make the most of his life. And when the opportunity to go to Australia came, we could not pass it up, but the fact that he had just had his 3rd surgery gave us pause. And so we sat down with the doctors and said, do you think it's okay to go? And they deliberated and had a conversation, and we decided it was a good idea to go. And yeah.
So there's a lot that happens between certainly the first few weeks and getting to Australia. So I'll backtrack a little bit. When I saw your talk at Global Genes last year, one of the things you talked about was the triumphs, right? These amazing triumphs, things that you never thought possible. And so you talked about the NG tube.
Yes.
And to me, that is just such a scary, overwhelming thing. And you became the NG whisperer, essentially.
Yeah.
So talk about that a little bit.
How many of your parents, like the first time, there's something disgusting with a kid, right, that you have to do. And I think this is true for any parent. I don't think there's anything that we went through is especially special, because I think every parent has had these same emotions for different things, right? So although our things were a little like maybe higher stakes, I think every parent will know the revulsion of having to deal with something disgusting the first time it happens. I'm not going to say what they are because we're being recorded and whatever. But for me, it was the NG tube. Do you know what an NG tube is? So an NG tube is, so Nadav was in the hospital when he was first born. He was not putting a lot of weight. To go home, he had to put on weight. To put on weight, he needed an NG tube, which was basically supplemental feeding through his NG, the nasogastric tract, right? Which is a scientific way of saying you have to take this yellow tube and put it through his nostril down into his stomach to feed him through a pump. I can see some of you are horrified. Like, that is the same look that you especially, like, that is the same look I had when I was told about this. And the worst part was, for him to be discharged from hospital, we had to learn how to place it. Because we're not going to have like 24-hour hospital staff. We're at home with him, and he has to have this in all the time. And if it comes out, which it does, we got to put it back in. So I was seriously grossed out and terrified of this. Well, like any
risk if you put it down the wrong.
Oh, it's just gross. No, the risk is.
And you put it down the trachea.
Yes, if you put it into the lung, that's very bad. So you have to learn how to do it, right? You learn how to prepare it. You learn how to place it. You learn how to check. You learn all of these things. You do it on a dummy. You keep doing it, and then they tell you to do it yourself, and then you do it yourself. And I mastered it. Like, I'm really, really good at it now. I haven't done it in a while, but I think I could. Like, not here maybe, but like, my secret talent is putting an NG tube in a sleeping baby in the middle of the night with it shit black without them waking up. Like, I can do that, right? And that is a skill that I've mastered, and that is part of like the pride that you feel when you're put in this situation. You can master these skills. I think any parent feels this, right? Like, I can do things that I didn't expect I could do before, and you grow because of your kids, because you're forced with these things that help you develop and grow. And this was a skill that I learned, and along the way, we had to learn certain skills that allowed us to partner with doctors to give them the medical care they needed. And part of that was learning the medical stuff. Like, we had to check his SATs, his oxygen saturations, frequently with this. I hope the person who made the device is not in this conference, because it's a terrible device that you put on the toe. You have to wrap it around. It always falls off, and it's inaccurate, completely inaccurate, this pulse ox. And it always comes, and eventually we just left it off because we could tell as parents what his SATs were. Like, just like that, we just knew. And every doctor's appointment we had to go, and they would do this kabuki theater of checking his SATs, and it would always come off, and they'd be like, wow, his SATs are 62. And it's like, no, they're not. They're 78, right? And that's normal. And they would check it, and eventually after 50 minutes, they said 78. So we learned all these medical things which allowed us to be part of the medical team, and we sought out doctors who not just allowed us to be part of the medical team, demanded that we were part of the medical team because we knew him medically in a way that they did not. And to care for him, we needed that. We needed that partnership.
So, again, there's a point in the book that you talk about. Nadav is older, and the staff are kind of talking down to him because he had the what did he call them? The leggy huggies?
This was in Philadelphia. Yeah. So Nadav was he was born. He might have been super smart, but we couldn't talk to him. But like, by the time he was in his third hospital in Philadelphia, after we got back from Australia, he was super savvy about what was going on. So he was a very old soul. This is a 4-year-old. But doctors learned very quickly not to talk down to us. And soon they learned not to talk down to him because he would correct them. So there's this one example which you're referring to in the hospital in Philadelphia where he was basically learning to walk again because he had been in hospital for so long. His muscles had atrophied. And he had to wear these like leg splints. They're called knee immobilizers with a therapist who were incredible. And one of the young doctors on rounds came to him and said, have you worn your leg huggies today? And he looked her right in the eye and said, knee immobilizers. Totally like put her in her place, right? So we weren't like a family that loved flowery, euphemisms.
Well, one of the things we talk about all the time in biotech, and certainly as patient advocates, is making sure the patient, the family is at the center of everything we're doing, and that we are listening to the inputs, right? That we're making the patients part of what we do. And in biotech, obviously, that's drug development, therapy, therapeutics development, but not to take the next step in your clinical development program unless you've heard from patients. And it's a very different experience, of course, going through the medical system as a family. But it's so remarkable to hear what a patient advocate he was for himself. And you talked, I think that when you were still in Australia, he was learning to talk through, be able to speak while he was intubated.
Yes.
Right?
Yeah.
And so talk a little bit about that. That's remarkable.
Well, I mean, part of it was him, but part of it was the therapists who looked after him. Like, we just have such a respect for everybody in a hospital setting, not just doctors or surgeons, but nurses, certainly, therapists, security guards, as you know. Like, there was a point where we visited the kitchens, that blew my mind. But certainly, the therapists were really helpful to him. And what was good about them was they really pushed the limits of what was possible. We use that phrase a lot when I guess we talk about drug development or new therapies development, but like therapists do that every single day. And while his surgery in Australia was terrible. It lasted 14 hours. He was on bypass for 7.5 hours. Like, it was an emergency surgery to address a thrombus, a clot in his Fontan circulation. He came out in very, very bad shape on ECMO and got off of ECMO, which is this heart-lung machine, which is terrible. You don't want to be on that for too long. And he's there basically passed out and intubated in the hospital, and this speech therapist shows up. And we're like, why do we need a speech therapist? Like, he's intubated and he's sedated. And she's like, oh, he can't talk. Well, he said, well, he can still communicate. Well, how? She realized, she knew that, let's start with his eyes. So we would talk to him and say, which book do you want us to read you? And he would just look at the book, right? And that was step one. And eventually she worked her way up to blowing bubbles to get like him back into that thing, which was insane, right? And then she taught him how to talk while he was intubated, which nobody had ever seen before. But it was because a therapist insisted that it was possible and decided to commit to that despite all the hardships and the craziness about it, right? And we saw that time and time again. Obviously, there's moments where you do not want people to try crazy things in your child, right? There's a limit to the aggressiveness with which you want to push things. But to know, like, this is the right way to push somebody towards what they can do, we certainly felt that as parents that we were pushed in positions where we didn't think we could do it, and we discovered we could do things, and he was the same way, and that was really remarkable to see.
So let's talk a little bit about the trip to Australia. So he's 4 years old at that time. And you talk in the book about just this wonderful time, seeing family. And so sort of what were the fun things that you all did while you were down there?
Australia is a wonderful country full of exotic creatures, things like
I'm terrified of Australia. I feel like every animal that can kill you is from Australia.
Yeah, but you learn to stay away from those things.
Okay, yeah.
Thanks.
Yeah.
Anyway, these wonderful creatures, exotic things, and the boys just loved. We went to the zoo, and we saw rabbits, and the boys were just like totally fascinated by the rabbits. And we're like, there's koalas, and they just really wanted to play with the rabbits, which was weird. Like, it's often the small things that you enjoy. Like, you learn not to push things too hard. You sort of meet the kids where you are. But yeah, it was great to see family. It was great for him to meet his cousins. They wouldn't have met him otherwise. They still have fond memories of him, right? Like, that was really important that we went, even despite what happened. Because if we had taken the opposite approach and didn't do it, then he would never, like, maybe he only had 5 years to live in this world. Maybe it was our job to give him the best 5 years he possibly could. Like, this is one of the things that we do not know, right? Like, if we had decided to stay in the States, would he have lived longer? I don't know, but you think about the quality of life as much as anything else. And I think certainly, like, the ability to go see rabbits and koalas and kangaroos and family members and all of that, they loved it. They loved it.
So you have this amazing 2 weeks, and right at the end of the trip, you notice that he's pretty lethargic. Doesn't seem to be doing very well. Sort of talk us through that and sort of the unique perspective that the physicians in Australia had.
Yeah, I won't linger on being admitted to a hospital and having to do emergency surgery and all that, right? Like, that's kind of a painful. I do talk about it in the book, but it's not fun. I talk to doctors a lot about like how they treat patients. They gave us this pager in the morning. He went in for surgery at 8 in the morning, and they gave us this medical device called a pager, and they said, we'll page you when we're done, and they didn't page us for a few hours, which was great. I didn't want it to end early, but then it was like 10 o'clock at night, and we're freaking out, and then it beeps. Anyway, he comes out on ECMO. He's like in really bad shape. And we find ourselves in basically the critical care ward of Sydney's busiest hospital, pediatric hospital. And all of Sydney's worst cases are there, and he's the sickest kid in the ward. And there's some really bad stories. Every morning I would read the Sydney Morning Herald, and there would always be a story which ended with the phrase, the child was rushed to Children's Hospital at Westmead. And then I'd go in to see him, and the kid would be there. So you'd like see famous critical cases. Yeah, but we found ourselves in this critical care environment, which was much different than the cardiology environment that we'd had. And we were dealing with doctors who approached the practice of medicine different than what we were used to, not just because they were critical care doctors, but also because they were Australian. And the way they do medicine is a little different there. And one of the things we would do, as we do with everybody looking after them, was we would bombard them with questions. Like when we first met somebody, we would ask them like questions, we'd have this big conversation, and they would say to us, you have to be patient because we have to get to know him. And I think in the States, I would have viewed that as a polite brush off and been a little insulted by it. But in Australia, what I realized what they were saying was, it's not our job to heal your child. We do not have that power. Only he has the power to heal himself. It is our job to put him in the best position that he can be to be able to do that. And to do that, we have to get to know him, right? We have to understand who he is. And I thought that was like a really, really profound thing. And I wished I had learned it earlier. And I really treasured that insight because it really does reframe the whole endeavor of looking after sick kids, right? In a really profound way. The other thing they did, which was remarkable, was while this kid, again, in critical care, is lying in this hospital ward, they decided to take him outside, which was really mind-blowing. The doctor in charge was like, we're going to take him outside today. This, mind you, is 24 hours after telling us that he was not going to make it, okay? Which was also a difficult conversation. I could talk about that too if you want, what it's like to have those conversations. Anyway, after doing that, they told us he's going to go outside. Why is he going to go outside? It wasn't out of pity. It wasn't out of like palliative care or anything like that. It was to help this kid heal, he needs to be in a healing environment, and being outdoors, and this is a very Australian attitude, I think, being outdoors is probably the most human environment you can be in. So they got 2 nurses, they got another doctor, they put on the red backpack, they slowly wheeled him out, they put him on a travel ventilator, and took this kid out to this garden in the grounds of the hospital where he was able to smell fresh air and touch leaves and look at the flowers and just be a kid in his own way and watch his brothers play. And it was the greatest gift. Not because it was like, I mean, it was obviously nice to be there, but to be in the world when you're trying to heal was really, really amazing. And they did that over and over again. In fact, they took him out one night to look at the stars, which apparently was not allowed. This was like an overzealous, junior doctor who decided to do this without permission. But we're glad to do that too. And in fact, throughout the rest of our journey, whenever we was in a situation that was medical, we tried to get him outside as much as possible, which when we were back in the States completely baffled everybody. Like nobody does that here. They're starting to. But like, you want to, well, where are you? You're not in your hospital room. Like, well, we're walking around this, garden. It was really weird. Yeah.
I thought it was so interesting because you do talk about in the book that the time going outside, right? And so there you have this medical staff taking him outside, and then the nurse who plucks the leaf and puts it in his hand so he can feel it. And all I could think about was being in this litigious American environment and where like you have to sign 12 consent forms because it could be poison ivy or something but it was such a natural human thing to do.
Yes.
And how that connected sort of this experience. And again, everything you talk about in the book I thought was so poignant. Yeah. And so, we won't belabor the point of sort of, the obviously was a very, very difficult time, but there's a point in time in which you're able to get a consult at CHOP in Philadelphia. You talk to the physician, and so the decision is made to transport to Philadelphia from Australia.
Well, it was not that easy.
Well, I know that.
You're making it sound very routine. It was not.
No, so talk about that.
So we're stuck in Australia. We're stuck halfway around the world with 3 of our kids, one of whom is in critical condition in Sydney's, most critical care ward, clinging to life. We've been told he's not going to make it. We've been told twice that he was not going to make it. But something about the doctor in charge, from the very first moment we met him, a guy named Nick Piggott, who's a remarkable doctor, said he should not be here. His place this is not his home. He needs to be back in New York. I'm like, well, how are we going to get him? He's like, I have no idea. And if anybody tried to do it, I'd be very suspicious because you can't transport a kid this sick. Australia is very famous for retrieval medicine. Like they have a big, vast country with sparse population. So moving people around and dealing with long distances is something they're pretty good at. But even this was beyond them. And so we basically felt pretty stuck, right? There was no reason to put him on a plane because he wasn't a candidate for surgery or anything. There wasn't even a treatment that could help him, right? Because he'd just been through the surgery and he was clinging to life. Another surgery could have killed him. So my wife, Tali, who really should be here, she's a big part of the book, and she's my better half in so many ways. She reads medical journals for fun.
She's an engineer, right?
She's an engineer. Yes, I'm not an engineer. She's an engineer. She reads medical journals for fun, and she came across this paper that had just been published in one of the pediatric cardiology journals about a new procedure that they were pioneering at the Children's Hospital of Philadelphia, which was called a Fontan takedown via catheterization. And basically what that meant is they could revert the third surgery, which if you want to hear the science behind it, I can tell you about it. Basically, quite a risky balancing act, the third surgery that you do for kids in this situation, called a Fontan. A way to reverse it without surgery through catheterization. This had never been done before, and it had been done on 3 kids, I think in this paper, 2 of whom had lived. That's how they phrased it. And to a parent, you hear one of them died. Right? That's how you hear it. But Talia was like, well, this is a possibility. If he's a candidate for the surgery, then we want this procedure, then we want him to do it. So she asked our cardiologist in New York to reach out to the doctor in Philadelphia. Everybody knows each other in this world. She reached out. And the doctor down there, a guy named Dr. Jack Rome, said, I'll evaluate him, which were 3 magic words because they gave us the medical justification to put him on a plane, right? The fact that he wanted to evaluate him, which not just meant that you could do it. Well, it didn't mean that you could do it because it's all complicated, but gave insurance a reason to agree to it, which, as we all know, is like the big blocker to care, right? From a parental perspective. So the doctor in Australia met with the doctors at CHOP on the phone every day. They worked out a way where they would bring our son home, or at least try to, in a Gulfstream 3. This is an incredible plane that was used for medical renditions, Ebola evacuations. It was used for when they were taking all the terrorist suspects to black ops places. They used this plane. This is the plane that you get when you need something done. And this doctor and 2 nurses and a respiratory therapist from the Children's Hospital of Philadelphia transport team pile into this plane in Philadelphia. They fly Philadelphia, Oakland, Hawaii, Hawaii, Fiji, Fiji, Sydney. They land. They're wearing these blue jumpsuits that say CHOP Transport on the back. They have American flags on their things, right? It's like astronauts coming to help take our kid home. And you put them on the plane and brought him back, which was further than anybody at Philadelphia had ever transported a kid this sick. And they do a lot of transport around the world. And they told us very clearly that if something was to go wrong, and there was a possibility that something would go wrong, they would stop the flight and just be done with it. So this was also one of these things I was talking about earlier, right? These risks that you take, educated risks that you take because the benefit is worth it. And they brought him back, and we ended up at the Children's Hospital of Philadelphia. He underwent the procedure that morning. Tali landed with him. I was on a different plane with the brothers. They did the procedure that morning, and suddenly we could hope for improvement and not just stability. So we actually were lucky to find ourselves on the cutting edge of medical innovation in a lot of ways, and this was one that actually allowed us to get home. Well, actually, I'm a New Yorker, and I'm in Boston now, and Philadelphia is certainly not my home. So we're very conscious of where our home is. So we were stuck in Philadelphia, what ended up being 6 months. The boys went home to New York, and we spent 6 months going back and forth as if the kids were divorced and sharing custody of us, or my wife and I switching places. So we found ourselves back in the States, at least.
So again, from a biomedical perspective, part of what is going on is this balance of pressures, right? You're creating this vasculature to oxygenate the blood, and so going at altitude on a commercial jet would have been devastating. And so what's remarkable to me is that the transport plane maintained an altitude at which the pressures could be sustained. So they thought of everything.
Well, they had to balance the fuel needs and the oxygen. They had to figure out how to put fresh frozen plasma on a plane and make sure that he was draining 9 liters of fluid a day at this point, which is insane for anybody who knows about this, and they had to replace that. My wife is an engineer. She loves all this stuff, right? She loves all the engineering behind it. It was a real complicated endeavor.
So we fast forward a few months, and things are going fairly well. And you say, while intubated, all of Nadav's nourishment had gone through his NG tube. He hadn't eaten in over 3 months, so his nurses asked him what he wanted for his first meal. Sushi, he croaked in a small voice.
Want sushi.
So what was that meal like?
The sushi?
Yeah.
All the nurses were like, this kid wants sushi? It's like, well, we got sushi in the cafeteria, so we went down to the cafeteria and got him sushi. That was a pretty celebratory meal because he'd been intubated for so long and he hadn't eaten real food, right? So that was cool. But if you talk about like being human, like
it's just a very Nadav thing to say. Sushi.
It is a very Nadav thing to say. And hopefully, like none of you met him. Hopefully you get to know him a little bit. If you read the book, I hope you get a chance to read the book, you'll get to know him. That was a big part of writing the book. So he'd meet all of you, so to speak, or you'd meet him at least. But it's funny because he had very unique tastes. Throughout his life, he had unique tastes. He didn't like ice cream. He was like the only kid I've ever met who doesn't like ice cream, which is horrible because if you're trying to fatten a kid up or give him calories, ice cream is the best. He wouldn't eat it. He would spit it out. And then after his surgeries, like his taste totally changed. He developed this taste. Well, I'll tell you. So after he ate the sushi, we started going down to the cafeteria every day to eat. And we noticed that he always wanted pizza, which was very odd because he never liked pizza before. I couldn't figure out why he liked pizza. And one day I realized he's actually taking the pizza and he's dumping dried oregano on it. There would be some days where he would take like 3 of these little cans and just dump it and just eat the oregano off of the pizza. And we realized it's not pizza that he likes, it's the oregano. He fell in love with oregano. He loved it. He wanted it on everything. If we wanted to eat something, we just put oregano on anything, except for ice cream. He still wouldn't eat ice cream. I've never had oregano ice cream. Is that even a thing? It is. Okay, well, we didn't try it. This is too late. This is the pace
Only
of
John
medical.
O'Brien would
this
know
is
that.
what I mean about knowledge outpacing us, right? Because if I had known then that that existed, we would have tried it. So we realized that nourishment in the care of a kid is a very, very important human thing, right? And we also wanted to get outside. So we found ourselves stuck in the Children's Hospital of Philadelphia trying to find open space. And one day we found this little courtyard in a distant ward, which was not a cardiology ward, that had a herb garden. And we discovered that there was fresh oregano at this herb garden. So every morning we would go to this herb garden, we would pick fresh oregano together for his lunch, and he would eat his hot dogs or whatever with fresh oregano on it, which was really, really nice. One thing about being stuck in a hospital for 6 months inpatient is that it gets really boring, really boring. It was so boring that I almost did not want to, I wanted to minimize it in the book. And I'm glad I didn't, because a lot of people in our situation who have read the book have said thank you for that chapter, like those chapters, because that's what they're most fascinated by, is how do you live in a hospital for 6 months? It's a whole different talk. The reason I'm bringing it up here is we ran out of things to do, despite the best efforts of the Child Life team, and Child Life is an essential part of care, because it's very human. And we ran out of things to do, and we were brainstorming things to do, and we realized the elevators had a button below 1, which was B, and we'd never been to B, so we're like, what's on B? We said to the Child Life person, what's on B? And she said, oh, that's just the kitchens. And we're like, well, can we visit the kitchens at CHOP? And she was like, yeah, I'll see if I can arrange it. So we one day, we pressed B, and we went down in the elevator to B, and we found ourselves in this Charlie Chocolate Factory wonderland of giant industrial mixers and walk-in freezers and walls full of oregano. It was just an incredible experience to see an industrial kitchen. But most importantly, we met the people there. The head chef was incredible. She was wonderful to talk to. We met the guy from the pizza station in the cafeteria who looked at Nadav and said, hey, oregano, yo, what's up? Right? And that was nice to meet him. And then Tali got to talking, because Tali's a fierce advocate for our kids, with the chef, and she said, well, he's a really picky eater. And the chef said, well, what does he like to eat aside from sushi? And she said, well, he really likes lamb. And she said, well, we have a whole lamb menu. It's our halal menu. When you say so, right? We can make him lamb. What type of lamb does he like? Lamb chops. Okay, well, that night we had lamb chops, cooked just the way he liked it, from the head chef. And every day we sent her a note saying what he would like for dinner, and as you can tell from the book, he's a picky eater, and she would do it. And again, it wasn't like a special favor. It was her part of caring for our son, and we realized that everybody in the kitchen felt the same way, that they viewed their role in the hospital as helping care for a patient's basic needs, which was eating. Which may be surprising to those of you who have just thrown away hospital food because it's disgusting. And I'm not saying all the food is great, but the motivations of the people who work there, they feel their mission just as much as anybody else in the hospital. And just because they're stuck on B and you never see them doesn't mean they don't feel that way. You asked about the title, More Than We Expected. I would never expect to have had that experience in a hospital and to be have my eyes opened to that sort of human connection with people.
And the security guards.
Yeah, everybody. You can tell everything you need to know about a hospital from the security guards, right? The way you deal with the security guards is everything you need to know about the hospital. Anthony Bourdain once had a book, Kitchen Confidential, where he talks about if you want to know what a restaurant is like, you go to the bathroom, and that will tell you everything you need to know about the restaurant. It's the same thing with hospitals and security guards. And if you get to know them, and they're amenable to it, which shows a sign of a good hospital, they will literally open doors for you, right? So we wanted to roam everywhere we wanted. We found ourselves in all sorts of really interesting places because we just waved hello to the security guards, and we got to know their names, and they got to know us, and yeah, fantastic.
So you shared in the beginning how the story ends, and you've written it in such a poignant way, and obviously heartbreaking. So I won't belabor that piece, but later you learn about this genetic mutation and sort of the odds of it sort of passing down the way it does. Can you talk a little bit about that?
So yes, I know a lot of people are interested in genetics here, so I'll talk about genetics for a second. We had no idea this was genetic. Not that we had no idea, but we didn't really care when he was born. Like, the immediate problems were cardiology. We had to get smart about cardiology. Whatever caused it was kind of interesting, but it wasn't like really applicable to our situation because we were treating the effects of whatever had happened. And it wasn't until we were discharged from Children's Hospital of Philadelphia that we determined what had caused it. Because we were asked before he left if he would participate in a genetic study for kids with heart defects. And we got back the results. The results were that he had a mutation in his H5 gene, which caused something called PCD, which is primary ciliary dyskinesia. And that affects the cilia in your body in lots of ways. Your cilia are present. We all have cilia, like whenever our respiratory system's full of cilia because it moves the mucus around, right? And for him, one of the problems with the cilia was, in what I just told you earlier, with the embryo, the cilia did not beat right? So this PCD caused the cilia not to beat right, which means the amniotic fluid was a little off, which means that his organs did not form the way that anybody else had, right? And so that was interesting to know that, a little academic, as I said. But what was even more interesting was they had us get tested as well, my wife and I. And it turns out, it's important to know that Nadav's mutation had never been reported before, this mutation in the H5 gene. Now, part of that is that it's incredibly rare. Part of it's that they hadn't really done a lot of this testing yet. So my wife and I got tested, and it turns out we both have a mutation in our H5 gene. We both have the exact same, never reported before mutation in our gene, which means that my wife and I have a common ancestor about 500 or 600 years ago who had this mutation and then passed it down through generations and generations and generations, right? Until we met each other and fell in love and unwittingly decided to have kids who resulted in this heart defect. And it really makes you wonder, and I'm using a little in the book, is what have I done differently? Right? Like, would I have not fallen in love with this woman? Would we not get married? Would we not have kids? Right? Knowing what we had known, like this medical knowledge that we had not had before. Now, I wouldn't have done anything differently. I wouldn't have done anything I wouldn't have changed a thing except the end, obviously. I would have changed that, right? But that was his life. That was what was meant to be. We wouldn't have met him or known him if that hadn't happened, right? If that mutation hadn't happened. And it gets a little profound. The other thing that really made us think, or makes me think, is Nadav's twin is completely healthy. He does not have the mutation. His twin, they're not identical, as you can tell from the photo. They're not identical at all. But his older brother actually has the same mutation. And it results in what? Chronic congestion in the stuffy nose, because his cilia don't work right. And so what caused his brother to have like the world's jackpot of cardiac heart defects and his brother to have a stuffy nose? I will never know. It just points to what I had alluded to earlier, that very human thing of knowing that there is something beyond your understanding. And maybe somebody will know. Maybe somebody in this room or in this conference will figure it out, right? And you'll have a therapy for it, and that'll be great. And that's the last thing, which is you have that regret, like, well, why didn't they have it when he was born? I firmly believe that the first heart surgery was in 1946, it's 2025 now, or he was born in 2011. And 75 years from now, they're going to treat kids with this condition like that. Oh, your son had a heart defect, we fixed it, it's fine, don't worry about it. Like, I firmly believe that. And you can see every 5 years there's innovations now that could have helped him back then. The fact that the lymphatic system is so poorly understood and is such an important factor in kids like our son who have this surgery called a Fontan. Nobody knows how important it is for two doctors, one who is currently at the Children's Hospital of Philadelphia, the other one is somewhere else. And luckily enough, we were in the same hospital where he helped us get home because he understood the lymphatic system, right? It does make you wonder about, why didn't we know? Why didn't we know? Why didn't we know? And I think accepting that there are some things that we are not ready to know yet is a critical thing, critical lesson for anybody involved in this whole world, whether it's a parent or a doctor or a researcher, being at peace with what we know now and having the courage to take that extra step, knowing that even if it's a tiny step, it might just move the ball forward a little more, even though a lot of it will be a mystery, is so critically important.
Thank you so much, James. This has been a wonderful conversation. We'll continue the conversation at the book signing just down the hall, so I do hope you'll come down and grab a copy, and I'm sure you'll take some questions there. And it's really been an honor to talk to you, and just all of us here, certainly at BIO and my team, we just have the greatest admiration for you and your family.
Thank you. If I may, you asked me why I wrote the book. So I've learned since my publisher published the book, why I wrote the book. A lot of people go on book tours to sell books. I sell books so I can go on book tours. And what I mean by that is, what's most meaningful for me having written this book is having these conversations. And so I strongly encourage you to come up with me afterwards. I think my email address is somewhere. And reach out if you're interested in continuing the conversation. Hopefully you'll read the book, share it with others, so that our son's life will help people in similar situations, but also being able to reconnect with this community as somebody who has lost a child is really important. I talked about all the strength and pride that you feel as a parent of a kid like this. Well, once the moment they die, it all feels utterly irrelevant. You feel cast out from that world, and all this knowledge that you've developed is useless. And so one of the greatest joys of having written this is now suddenly our story can help people or connect with other people. So I do encourage you to reach out and connect with me because it means a lot to me.
Thank you so much.